And good afternoon, it's Dr. Ara Deuk-Majan with the Deuk Spine Institute. We're getting ready to perform our third surgery for the day. We have broadcasted the first one and the third one. The second one we put into another operating room, so we don't have our broadcasting equipment. That's why we weren't able to broadcast the second one. But this is number 3, and this patient will be a lumbar. All right. Very good. Let me see the MRI, please. So our patient is having pain in her back and legs. Can I see this? From problems with her spine. Those problems, that's good, the other way. Those problems include herniated disc, degenerated disc. Okay, fine. Thank you. Slip disc, slip bone, spondylolisthesis, scoliosis, all kinds of stuff going on. But the back pain itself, we believe, is coming from 3 discs, which we're going to repair today. She's already had piriformis treatment. She also had piriformis syndrome with 2 torn muscles in her buttock, which Dr. Patel already injected. All right, can you hear me? We're going to get started. So what's on the left side?
The left side is 4-5 and 5-1.
All right, this is the left side. Everybody agrees? I'm going to give you a little numbing medicine, a little stick and burn. So I have to numb her up. And then we're going to, yeah, I'm sorry about that. The left is 4-5-5-1, the right is 3-4-5-1. So she's really a bilateral 5-1, as we've said. All right, so we need to get down to the L5-S1 disc shot. We're going to use our x-ray machine. So what we need to do here is I need to see the back a little bit more. So open up the field of view in the back. Open your collimator, that's good. It's too far south is what I suspect. Shot, probably still too far south, yep. Need to be a little bit further north. Yeah, oh, is this just prepped out for Patel? Is that why you guys had all that prepped out?
No. I mean, he did it before and then I prepped.
Okay, yeah. Yeah, no need to have that much exposure down low. You know what I mean?
Yes, sir.
All right, so that's local medicine we're giving her to numb things up and make it a little more comfortable. Shot. Yeah, you're too far north. Not sure why you guys went north. Don't go north. Clean up 5-1. That's where we're going to start. Shot. Shot. So the first thing we have to do is get down to the spine, which is what I'm doing right now. And the goal is to get to the back of the tear in the back herniation at 5-1. And it's pretty much the same for everybody. Shot. So we're getting closer. Are you okay? Shot. So I'm just about to enter the foramen. I want to get an AP view, which is a front back view, and just see where I'm at on the front back view to make sure I'm not too lateral or too medial. Now she's got a spondylolisthesis at L5-S1, so actually not doing too bad there. All right, let's go back to a lateral view. So what I'm trying to do, you can see the needle coming in from the left. I'm trying to access the foramen, the neural foramen at 5-1 on the left side, and go through the foramen and get into the 5-1 disc. So I'm choosing a trajectory that I think might work. And right now I'm encountering some bone, which is going to be the facet joint. There we go. Shot. So, are you awake? She awake, reliable? Shot.
Are you awake, sweetheart? She
Shot.
said yes.
AP. All right, so now that we're getting close to the back of the disc, I want to make sure I'm clear of the nerve root. I want to be below it and medial. So we need to look at our AP view because we're about to enter the disc. And that looks really good. Mm-hmm. Mm-hmm. Well, let's see. Sean, where do you feel it?
Sweetheart, where are you feeling the pain? Where in your leg? Huh? Tell me where.
We should be well below her nerve root, but
What? Left leg.
how far down her leg?
How far down your leg, sweetheart? How far? Halfway, knee, or all the way to your toes? All the way down, twist.
Mm. Is it still there?
Still feeling it? Yes or no? Yes.
Was she feeling it the whole time laying here? Shot?
Were you feeling it the whole time you were laying here? Or just when he started working?
All right, so our patient's awake. We're asking her questions
She felt it before he started working.
before. That's what I thought because I haven't really gone anywhere near it. All right. How's she doing right now?
How are you doing, sweetheart? She said, I'm okay.
Any pain?
Any pain? No.
All right. Tell me when she has any discomfort.
Having any discomfort right now? No? Tell us when, okay?
Anything?
Any discomfort? Any pain? No.
No. AP, let's go look at the AP again. So L5-S1 is the hardest disc to get into through the foramen. It's universally true for everybody in a lumbar spine. The easiest is going to be probably L4-5, L3-4, then L2-3. Yeah, it looks really good to me. We're right at the lateral border of the disc. So this is where her nerve is getting pinched the worst at L5-S1, by the way. You okay?
How are you doing, sweetheart? She said, I'm okay.
She have any pain?
Are you having any pain? Any pain? She said no.
Anything?
Where's your pain? In your buttock, in your back? Back?
In her back. All right. Well, we're in 5-1. Shot. I feel pretty good about that. And we've had the patient awake and telling us that, you know, she has a little discomfort in her back, which is good. I want to make sure I don't get too close to any of the nerve roots because the nerve roots are going to be just above and medial, just above where I'm working and even lateral. All right, so this left side is 4-5-5-1, guys. 4-5-5-1. We're all in agreement. Shot. I just want to make sure. That's bothering her back? All right. Sorry about that. How's blood pressure? Good? All right. Shot? Now, our last patient that we just did, our first patient was from New York, right? And she was a 2-level cervical Deuk laser disc repair. The second patient was from the only one from Florida, right? Because the next one, this one is from Canada, and the last one is from Australia. So we have a multinational day today. All right, let's get an AP. So once again, first patient we did this morning, if you go back to YouTube and watch a 2-level cervical Deuk laser disc repair, was the patient was from New York. The second patient, who we didn't video because we went into a different operating room, that looks good. That patient was from Titusville, yeah, which is where my son was born, and daughter, both son and daughter. And then this patient, of course, is from Canada, as we've said. You all right? Yeah. Well, we're close to where the pain is coming from. So, shot. Yeah. You okay?
You having pain in your back?
That's where your bad disc is. So, we're just passing her facet. And her herniation here is good size. Is that better? All right. You're doing great, by the way. I know it's hard to believe it, but you're doing really good. Shot? Where does that bother you? In your back. Shot? You okay? All right. 2 down, 2 more to go. Okay? So we're going to be putting her to sleep soon, but not yet. I need her awake to make sure we don't get too close to any of those nerves we talked about. Going to give her a little more numbing medicine. Yeah, you're fine. You're doing great, by the way.
Hang in there. Little numbing shot.
So people always want to know, why do you have to be awake for the surgery? The reason is that I need to know that I'm not too close to any of the nerve roots. And the patients will always tell you when you're too close to a nerve root. Very reliable. All right, just relax. You're fine. One of the nice things about this particular surgery is that you don't do it under general anesthesia. We do it with local. So believe it or not, that's a lot safer for patients, because you don't have to give them general anesthesia, which is very stressful to the body. You're okay. You're doing great. Shot. So I want to access L5-S1 through both sides. Where do you feel that? I can't hear her.
Where'd you say? Right there.
In your back.
Right there, yeah.
Yeah, I'm sorry about that. We're almost done. Where is that?
Right there.
All right, you're doing great. Shot and then AP. Now, she has a herniated disc on the right side at L5-S1 and on the left side. And those herniated discs are literally pushing on the nerves as they're leaving the holes called the neuroforamen. You can actually see it quite nicely on her MRI. And so to get rid of her leg symptoms, we have to do surgery on both sides at a 5-1. Now that's not true for L4-5 or L3-4. L3-4 and 4-5. At 4-5, the herniation's on the left. At 3-4, the herniation's on the right. So we're only doing bilateral at L5-S1. And isn't that lovely? That's the level that I love to do the most, right? It's the hardest level. So they never want to think about their surgeon and make my job easy. Shot. They always just come with whatever they come with, right? You okay? Yeah, I know it's a tight fit in there. Shot. You're doing great. Where do you feel that? Huh?
Right there.
In your back. So I'm getting deflected up. But I'm wondering if that's a true deflection or if that's just the way that I'm seeing it on the fluoro. Let's get an AP. Now, if I were to do her surgery open with a fusion, you'd be looking at a much bigger surgery. She wouldn't be able to have it done. She has, basically her heart would not allow it. You know, some people have heart disease that precludes them from having open surgery. So this is a perfect alternative for someone who, you know, needs to have a minimally invasive procedure to fix their problem. The only other way for me to fix her problem would be a major surgery. Going in and cleaning out all the discs. Let's do a little WAG. I think we're off on WAG just a little bit, and maybe even a small amount of orbit. Can you clean up the 5-1 disc a little bit, Shot? That's worse. Let's go the other way on WAG. It's really important if you're going to do navigation with an X-ray machine, folks, that you have the X-ray lined up with the spine. Oh, see how that changes everything. Interesting. Yeah, that says we're in the right spot. Okay. Well, she's telling me I'm in the right spot, and now the X-ray is telling me I'm in the right spot. She okay? Shot? Huh. That is interesting. It's kind of deflecting. What'd she say?
What did you say, ma'am? She trusts you.
I know. I appreciate that. I'm sorry. I know it's uncomfortable. Shot? This is the worst part of the whole surgery. Once we get past this, it'll be a lot better. I may have to start a little higher. I think we'll be all right. I think we can get 3-4 and 4-5 here.
Thank you very much.
We're just so close.
I feel a little bit here.
What can you do to improve that image? I think it's a bit overexposed, and I think we're too far south. If that's accurate with the pedicles, then we need to go further north with the unit. All right, now we're off on orbit quite a bit. That's better. That's better. But our WAG, I think, may be off a little bit. No, we're overexposed. Show me fix the WAG a little bit. I'm still off on orbit too. You got to be able to see the spine three-dimensionally in your mind and relate that to the X-ray. Not really happy with that. I'm going to try to come down again. Shot? You're okay. Shot? Shot? Can you get that pedicle lined up as best you can? I want to see that 5-1 disc. I think you went too far north. Shot? Shot. I may have to finesse this one. Shot. Yeah, it just keeps deflecting up. Let's get an AP. So right now I'm talking to my team, particularly Jordan, and I'm asking him to move the x-ray machine around to different angles so that I can see where the needle is. The needle is basically going to be my guide to fixing these discs. The two of them on the left side are perfect. On the right side, I am right at the entrance, and I may have to just, it's starting to deflect a little bit up from the bone spurs. Yeah, that's what's causing the deflection, in case I haven't said it. But the bone spurs are causing the needle to deflect. And so the question is, should we continue, or should we be happy where we are and put her to sleep and then try to work it from there? And I'm thinking we need to put her to sleep.
Okay.
No, not now. I mean, I'm thinking for this right 5-1. So, yeah, I'm talking and thinking out loud. I want to share my thoughts so people can understand what's going through my mind as I do this. That's where my experience comes in. All right, so I've done what I can on the right at 5-1 in terms of positioning this needle optimally to where I need it to be to gain access to the herniation to fix it endoscopically. So now I'm going to go after the 3-4 disc. Right, 3-4 is next. You agree?
Agree, sir.
So let's get a better fluoro picture. All right, we got to do better than that, I hope. Shot. We're so dark up there. Is there a reason? Shot. You're okay. You're doing great. You're doing great. I know. Shot. Uh-huh. That's the facet. We just got to get around that thing. Shot. Shot. You're okay. Shot. You were doing great here. Shot. Where do you feel that? The picture is not so good, guys. What can we do to improve that picture? Just lay still. You're doing really good. Shot.
The L4 machine's better.
I'm sorry?
The L4 machine's better.
Don't say that. They're not going to be happy to hear you say that. Shot. I don't know. I think it's post-processing. Shot. All right, so we're off on orbit, by the way, by about 1 degree. If you can fix the orbit, maybe 1 degree or 2, that's better. And then let's get an AP, see where we are. This will be the last needle that we do place. And I'm going to place it at 3-4 on the right side because that's what we're supposed to be fixing, is the right 3-4. I think the orbit's better. Yeah, that's not bad. You can see the needle is almost at the mid-pedicular line. So we're definitely good. We're coming way underneath the nerve root that's exiting from the pedicle above. You can see the disc space. So yeah, I'm happy with that. Yep, that looks good. She's doing really good. Just relax. We're almost done. We're going to put you to sleep soon. Shot. So. All right. Shot. Shot. You okay? She's got humongous tears in her disc. Humongous. I mean, that thing just went right in. Yeah, it's better, but it's still a bit dark.
I think what is going on is picking up at least bowel gas pattern.
Yeah.
It's because it's causing not
Yeah. All right. You okay? Are you in pain or are you comfortable? Huh?
Change the light.
Is she having any pain right now?
You having pain right now, sweetheart? You okay?
All right. You're a good girl. You're tough. I know you're tough. So we are fixing 3 discs today. She has degenerative herniated discs at L3-4, L4-5, L5-S1. And that's what I've done here is I have drawn the discs on her skin for you so you can get an idea of what's going on inside. Now on the L3-4, okay, can you guys see this all right? You're doing great. Lay still. There's a tear on this right side and the jelly has pushed through the tear. Okay, and I think that disc is very painful. And then at L4-5 on the left, she has a tear and the jelly from the center has pushed out through that tear. At L5-S1, she's got a slip and she's got herniations on both sides. So we're going to do a little test to see, are these discs really hurting her? You okay? How bad is that on a scale of 1 to 10? How high does it go? Sorry about that. How high does it go? Give me a number, 1 to 10. Can you talk to her and find out what it is? What's the highest it went?
10.
All right. So is that where you get back pain typically?
Yes.
Okay, she said yes. So that's a 10 over 10 and C means concordant. Concordant pain means that's the typical pain she gets every day. I didn't just create it. I just elicited it, but I didn't create the pain, huh?
We should do the other one, 5 is on the other side.
Yeah, I know.
Okay.
I was going to put the stylet in, but. All right, so we know that L3-4 is a 10 out of 10 and it's concordant. It's the kind of pain she gets every day with her activities. That's the pain we're targeting, by the way. You all right? Better? Did it go away? Okay, you feeling all right? Did you see her lurch her body up and you heard her, right? Shot? Shot? No. Oh, that was 5-1.
Yes.
Okay. How bad was that on a scale of 1 to 10?
10?
Yeah, she's smacking the cushions on the bed. So basically we tested the bottom disc. You can see that dark material. It's still over dark. It needs to be a little bit better exposed. Yeah. So the L5-S1 we tested through the left side, and it's a 10 over 10. You're going to get to watch your video later on when I send it to you tomorrow. When I see you, I'll give it to you. But basically we know that this disc is a 10 out of 10 pain. This disc is a 10 out of 10 pain. You're doing great. We're going to put you to sleep in just a minute, all right? And then I'm going to do your surgery and fix your back with the Deuk laser disc repair. That's why you came from Canada, right? You didn't just come here to see my smiling face. You came here to get fixed. Yeah, we're going to get rid of it. So, are you better? I'm sorry about that. But you know we are fixing 3 discs today. I'm sorry. How bad is that on a scale of 1 to 10? 10. All right, you're done. I'm done torturing you. You didn't think you'd come to Florida to get tortured, did you? I'm so sorry. We're done. We're done. We tested all 3 discs, and all 3 are causing you 10 out of 10 back pain. And that's where you typically get pain, right? All right. I want you to count from 1 to 100 in French. Can you do that? Is she counting in French? I'm just giving her a hard time. You know, I'm being one of those silly Americans. So great news for her. She's come down here because she's been suffering with back pain and leg pain for years. And we figured out where her pain's coming from. It's coming from 1, 2, 3 discs plus the piriformis muscle on both sides. And Dr. Patel has already done piriformis injections earlier. So now I'm going to fix these discs. All right. So the first one I'm going to fix is going to be this left side at L4-5. Shot. So I'm going to put my guide wire. I'm going to take out the needle. And I'm now, you got to be careful because sometimes when you try to pull the needle out, it'll pull the guide wire out. You don't want to do that. Next, I'm going to bring down the dilator. People ask me, well, when you go into the disc, don't you cut the disc? No, we're going in through the tear that's already there. And we're going in through the damaged part of the disc. That's the beauty of this surgery, it's transforaminal surgery. It was developed by Dr. Parvis Camden at Pittsburgh years ago, and he figured out why should surgeons go in the middle of the back, open everything up, and move the muscles and peel them off the spine and kill them, basically. They turn into scar tissue, and then start ripping out bones and ligaments here when the problem actually can be gotten to through the side. And that's what we do. We do a transforaminal approach. You can actually see the herniation there, just in front of the dilator shot. Yep, so the dilator, literally the tip is kissing the herniation. You can see the bulge back right there. That's what the dye is around. Lay still, you're doing really good. This will be fixed before you know it, and you'll be going home. So she's here with her family. Shot. Now I'm entering that disc. Yeah. So guide wire's out because we're inside the disc. Big tear, shot. She's got a big tear in there. Okay, we got the dilator in. Next, I'm going to bring this tube over the dilator. And all of this equipment is FDA approved for this surgery, by the way. Once I get the tube in, we'll take the dilator out. Any questions from our audience?
Yes, sir.
Go ahead.
We have one from Alan from Facebook.
Sure, Alan.
Does moderate foraminal stenosis
Foraminal.
mentioned on the MRI always mean there's some sort of nerve pressure in pigment?
Yeah, great question. Does moderate foraminal stenosis mentioned on an MRI mean that there's some type of nerve impingement? The answer is no. You'll know when the nerves are getting impinged upon or pushed upon because you'll get symptoms in your leg: numbness, tingling, weakness, paresthesias, which is tingling, and then even pain down your leg. So if you're not sure, you can always get a nerve test done, which will tell us if there's nerve damage from the stenosis. Great question. I hope that answers it. All right, let's go ahead and run the first animation video so everybody watching can understand what are we doing here. Why are we going in and fixing discs to cure her pain? And the reason is simple. The number one cause of back pain, chronic back pain, is an annular tear within the back of a herniated disc. The annular tear in the back of a herniated disc. And that's what we're going to go fix today. But let's start with, how does an annular tear and disc herniation cause pain? The answer is through inflammation. We'll watch the video.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Endoscopically visualizing the inside of the first herniated disc. This is the L4-5 disc herniation. We're literally inside the tear, the annular tear. When I say tear, I mean annular tear. And we're seeing part of the herniation right there, the blue stuff. So we're going to remove as much of that herniation as we can. There's a lot of scar tissue from inflammation. So we're going to keep going with the laser. This part with the laser is called the annular debridement. It's essential to getting rid of the back pain. If you don't use the laser, you're not going to get rid of the back pain. So all these surgeons out there that do endoscopic surgery without a laser, they can't get rid of your pain in your back because they're not doing an annular debridement. The annular debridement was first discovered by me, Dr. Deuk at Deuk Spine Institute, years ago, and we actually published our findings in the medical literature. You can find our studies on the Deuk laser disc repair. In 2012 was our first peer-reviewed publication on this procedure. It described for the cervical spine how it's done. It's pretty much the same for the lumbar. It's just a different approach. Come on. Now the laser fiber is the blue thing you're looking at that I'm moving around. It's under my control. I have a foot pedal that actually allows me to turn it on and off. The laser itself that generates the laser beam is near the foot of the patient. It's a big machine. It's the size of what? A big box? Size of like a small dryer, right? Or a washing machine, just for reference. And it's probably the most expensive washing machine you've ever thought of because it costs over $100,000 for one of those things. They're very expensive. But not as expensive as our fluoro machine, right? Which costs twice as much almost. So, long story short, I'm just pointing out that this surgery requires about $1 million worth of equipment to perform, and the laser itself is a holmium YAG laser, medical grade. It generates the laser energy, and then we transmit the energy from the machine to the end of this little glass fiber you're looking at. Just like fiber optics are transmitted, you know, the internet and all the fiber optic stuff that we use to communicate across the ocean, transatlantic cables, it's all the same thing. It's basically electromagnetic radiation that's transmitted through glass fibers, long glass fibers. There's a program I watched on how they make these glass fibers, and they basically take hot glass that's molten and they drop it from a tall tower. And as it drops, it stretches thin, and it reaches a certain thickness that it just maintains for about 20 feet or 30 feet. And then they cut that glass fiber and they connect it to another piece. They weld them together basically. So they're very expensive to make, obviously. And that's how you transmit information across the internet overseas from one country to another, is through glass fibers. They call it fiber optic. Optic because it uses visible light waves, I guess. I think it does. I'm not sure what the actual waveform is for data. I know with the laser it's in the very high nanometer range, I believe. So high frequency, more energetic electromagnetic radiation compared to visible light. right, but the laser we use is a medical laser, and it's used in other applications in medicine as well for removing kidney stones or removing prostate cancer or other types of lesions, which I won't go into. But we use it here in the spine. So it's also used for brain surgery, to remove brain tumors, to kill brain tumors. That's a newer technology as well. I actually wanted to start doing brain tumor laser surgery here at Deuk Spine. Of course, we'd have to call it Deuk Brain. But that was years ago. I just don't have the bandwidth, the time to do everything. So at some point in the future, we'll probably offer laser brain surgery for people with metastatic lesions in their brain using a navigation process that's very safe, and the procedures can be done outpatient, just like our spine surgeries are.
We have a question from Joseph from YouTube.
All right, Joseph, bring it on.
With the Deuk laser disc repair, do you take a transformational or interlaminar approach for a central lumbar disc herniation?
Yeah, great question. So if somebody has a more central disc herniation, do you take a translaminar approach, interlaminar approach, or do you do transforaminal? The answer is transforaminal, just like we're doing now. There's a piece of herniation, by the way, a nice one. And what we have to do, though, is we have to start a little lateral, more lateral to the side, and aim more medial. And that will allow me to get more medial. The translaminar approach is not a good approach because you have the thecal sac and all the nerves in front of you. And you can't go through them, otherwise you'll get a spinal fluid leak, which a lot of surgeons get trying to go through it. And it's a bad idea. This is the damaged part of the disc right here. This is the annular tear you're looking at. And the blue is, not the blue from my laser, but the blue right here at the tip of the glass that I'm removing is degenerative nucleus pulposus. And it's degenerative because it's been stuck within the annular tear. And of course, being stuck in the annular tear, it's created an inflammatory response within the annulus. And that inflammatory response is where all the pain comes from. So by cleaning up the annular tear and removing the herniated disc material, we're going to get rid of the inflammatory response. And therefore, we're going to get rid of the patient's back pain and get rid of their leg pain by getting rid of the inflammation and by decompressing the nerve root. Great question, though. Okay, I'm just pulling my way out of the tear from the inside out. I've described this before. This is called the inside out technique. It was developed by Dr. Anthony Young many years ago. I was a student of Dr. Young in Phoenix, of his technique. And it's a technique that's been adopted by a lot of people that do endoscopic surgery in the lumbar spine, starting basically inside the disc and working your way out. Therefore, it's called inside out, as opposed to outside in, where you start outside the disc and work your way in. Some surgeons that do endoscopic disc surgery in the lumbar spine do a out to in approach, which I don't recommend and I don't perform. I know how to do it, but I don't recommend it. It's, in my opinion, a very bad approach. You're right where the nerves are, and you can actually do a lot of damage to people's nerves. And it doesn't seem to bother some people, but that's why you do the inside out technique, to be safer. This is the disc herniation laterally within the annular tear. We're actually in the lateral foramen right here. You can see how much scar tissue there is associated with this herniation. That over there is the end plate. So just about done. How is our patient doing? Good? Great. So, great question. Do you want to run the next video animation for our guests so they can learn about the Deuk laser disc repair and how it works?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
So we are still at the same disc, just finishing up. Just a few more minutes. I'm almost done here. Our patient is snoozing blissfully as we're in here repairing this disc. And we were just talking about the unfortunate accident that happened locally in Orlando last week on Thursday. A young man fell out of a ride called a drop, something like that, a drop ride, and died. And we were just talking about, you know, the sadness of it, and it's all over the news. Yeah, so you guys think it'll be closed permanently, huh? It's possible. All right, stand by. Do we have any more questions from our audience?
Yes, sir, we do.
Okay, thank you. If you could read me the question. Just about done here. One more minute.
Does the Deuk laser disc repair vaporize the disc herniation, or do you pull out the herniation like other spine surgeons?
Great question. So does the Deuk laser disc repair vaporize the disc herniation, or do I pull it out with grabbers like the ones I'm using right now? The answer is both. Some of the disc gets vaporized. Some of the, not disc, but the tear and the herniation get vaporized, and others get, big pieces get pulled out. So it's a combination of laser vaporization and mechanical removal using the pituitaries, which is the name of that instrument I was just using. Pretty standard instrument to use in spine surgery. The pituitary rongeur. It's actually named after a a gland that's found in the brain called the pituitary gland. And the tool is used to remove pituitary tumors during brain surgery, but it's so useful in spine surgery that a lot of spine surgeons use it as well. So, being a neurosurgeon, I use it in brain surgery and spine surgery, both. Good question. All right, we are at the end of the annular tear, and I've gotten rid of the herniation. I've gotten rid of the nasty scarred up annulus. And you know what amazes me here, to be honest, is this disc actually looks pretty good. You know, it's pretty well preserved. It's not so degenerated. I've seen far worse discs, far more degenerated discs. So, given her age, this is a pretty good one. You know, I'm sure we're going to see a more degenerated one soon, but for right now, I'm pretty happy with this. It's looking good. A lot of scar tissue here from the old herniation. Just about done.
We have another follow-up question from Joseph.
Sure.
What are the side effects if a surgeon removes more discs than he should?
What are the side effects if a surgeon removes more discs than they should? There's really no side effects. That's the beauty of the procedure too, is that you really can't remove too much disc. Let's say you took all the disc out, 100%. It would literally be bone on bone. And bone on bone, what I found over the years is it really doesn't do anything to harm the patient in any way. There's lots of bone on bone discs where there's no disc left at all. And patients do fine. They have no complaints whatsoever. So it's not the bone on bone that's a problem. It's the inflammation within the annular tear that's the problem, just as we've been saying for years. So as long as we get rid of that inflammation in the annular tear, the patient should do just fine. By the way, we're not removing disc, and that's an important distinction you need to understand. We're removing the herniation. So it's kind of like a toothpaste bottle. If you open the cap and you squeeze out a bunch of the toothpaste on the counter, and then you go and clean the toothpaste that's on the counter up, well, you're not removing toothpaste from the tube. You're just removing the toothpaste that's already outside of the tube. So we're not really removing disc inside the disc. We're removing the herniation, the disc material that's already herniated. So that's important to understand. But the first answer I gave about you could take the whole disc if you wanted to, and the patients don't have any symptoms, that's true. But we're not taking the disc out here. We're just removing the herniation. So the herniation starts right here where you're seeing the tip of this glass laser fiber is, right there. That's where the herniation starts. And it travels all along here and ruptures to the outside. Yeah, that's fine. Thank you. So, anyway. Thanks. We're done here. Let's see if we can see the nerve root. Yeah, there's the nerve root right there, the white thing on the left. Looks good. So we're just underneath the root, and I'm very happy with the surgery. It looks great. We're done here. Remember, we still have a few more to do. This is just the first disc. Just a little antiseptic. We've never had an infection in any Deuk laser disc repair. I've done over 1,400 of these surgeries in 16 years. Not a single infection. Now you can't say that for any other spine surgery out there. I can't even say that for my fusions. I haven't had a spinal infection in a fusion in many, many years, at least 9 years. And I attribute that to the fact that I use something called vancomycin powder, which is an antibiotic that prevents infections. We use that vancomycin powder when we do fusions. I sprinkle about 1 gram or sometimes 2 grams of it into the wound bed, and that prevents infections from happening. So we've never had an infection with the laser surgery either. Lateral, please. All right, it's important to apply pressure when you take the tube out because you've basically spread the muscles open and you want to make sure there's no bleeding that's happening. So sometimes bleeding can happen inside the patient and you won't see it. So it's important to apply pressure even if you don't see bleeding. And make sure you hold it just for a few minutes. And that way if there is some bleeding, it's small bleeding, it stops quickly. All right, shot. So we are going to L5-S1 shot. And this is a disc that we're going to try to get to from both sides. Okay? But we're starting on this left side. Because we've already started doing surgery on the left, and then I'll switch sides and go to the right. All right, so here we go again with the dilator. We're going to follow the guide wire down to the L5-S1 disc. This is transforaminal coming from the side. You can see the guide wire down there, shot. It's actually in the disc space at 5-1, almost at the front. And I can feel the hypertrophied facet joints, shot. Now remember, the window that I have to work here is extremely narrow. This patient has tremendous arthritis, and arthritis means that the facet joints back there are really gotten 2 or 3 times bigger than normal. There's a thickened capsule around the joint. There's all kinds of synovial hypertrophy and all kinds of grungy material. So it's basically impeding the movement here of my dilator. But the dilator is following the guide wire, shot. Shot. Making slow progress, but progress nonetheless, which is always good. And this just highlights how narrow the space is to work in here. There's not much space. So now I'm going to try a little different technique. Now that I'm entering the disc, I don't want to hit my guide wire, and so I'm going to bring out my impactor and I'm going to try to drive this thing in, following the guide wire, which is the safe path. It's nice. I'm going to pull my guide wire back a little bit because it's trapped just slightly and advancing, and I don't want it to advance with the dilator. Shot. Inside the disc, I can feel it opening the disc. So I feel like we're inside the disc. I'm safe here. I'm going to go ahead and take out my guide wire, and I'm going to finish this just like that. You want to get about 2/3 of the way in, and then we're going to bring our tube down. Now the whole surgery is done through this skinny little tube, so there's no need to open her back up. Now look, if I was doing the alternative procedure to fix her back, get rid of her back pain, get rid of the pinched nerves, I would be doing a decompressive laminectomy, foraminotomy, osteotomy, and inner body cages at 3 levels with pedicle screws, rods, and crosslinks. That surgery is about 4.5 hours, and you're talking about cutting her from here to here with everything filleted open. It's really, really painful surgery, even if we do it with all the most advanced pain prevention. And the patient will take months to heal up from that surgery. So the endoscopic alternative is so much better. It's far less invasive, much safer, and compared to my fusion results, I get about 95% elimination of their preoperative back pain and leg pain or leg symptoms with both surgeries on average, about 95%. So from a getting rid of symptom standpoint, they're equivocal in my hands when I do them. And I have really good fusion results. On the other hand, the recovery for laser is overnight, basically a few hours and you're done. With fusion, it's months. Shot? So why don't you run our audience the comparison video so they can understand the difference between this Deuk laser disc repair endoscopic surgery versus a fusion surgery.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Okay, so we're just about done here at L5-S1. This is the bottom disc, and boy was she having trouble here. Her nerves are getting pinched. You can actually see a bone spur. I just obliterated it. If you want to hit rewind, you can see it. But this is all bone spur from the herniated disc and bone spur together. So bone spurs are created by just basically the body calcifying bad tissue, abnormal tissue. It's called dystrophic calcification. And what happens, you get a buildup of bone spur and other material, and then it just starts pushing on the nerves as they exit the spine. Stand by. So this is all a bunch of scar tissue and herniated disc material that was pushing on this nerve root as it's exiting here at L5-S1. And hopefully we're going to see the nerve root in a minute, but it's protected by this tube that I'm using. And I've pretty much gotten all the herniation I can out. We're pretty much done. I may want to get a little more right there, a little bit left of that inflammatory tissue. And honestly, the discectomy is really a debulking procedure. You're debulking the herniation. You're getting rid of the mass. It's the mass that's pushing on the nerves. Yeah. All right. Here you go. That should be. I think that's it. Let me just check. Yeah, there's the nerve right there with a little. Look at all the scar tissue on the nerve. Look at that. All that scar tissue right there. That web of white stuff. That's the nerve root. And there's a little bit of disc material still stuck here. I just want to try to get as much as I can. How's she doing? Mostly scarred. Herniation. Yeah, she doesn't like it. This is the pain generator. But every little millimeter I can get out helps. That's it. I've done it, everything I can. All right. Well, I'm just helping you with her ejection fraction. Trying to get it to increase a little. Off. Right? Little stimulation to help the inotropic. That's right, inotropic and chronotropic. So I'm just cleaning out the area that I worked in just to make sure we don't, obviously we don't want an infection. We don't expect there to be one, but it's always good to, we do irrigation. It's pretty standard technique. The holes here need to be unclogged. There we go. I may need to do one more.
You want more irrigation?
I think we're okay.
We're halfway there.
2 more to go. All right, so done at 5-1 on the left.
Now it's gonna switch. I'm gonna.
And the reason it's tough to get out is the space that we have to navigate through is extremely narrow. So I have to navigate that needle and tube through a space between the transverse process, the facet joint at L5-S1, the sacrum, and the iliac crest. And it literally, all of those bony structures are bigger than normal because of arthritis at joints. The arthritis makes their joints enlarge over time. They can get to be 2 or 3 times bigger than normal. I've seen that, sometimes even bigger. And when the joints get bigger, it makes the passageway for me to get down there even more narrow. So that's why, you know, of the few endoscopic spine surgeons in the world that exist, I'm probably the only one that does L5-S1 transforaminal on a regular basis. Literally the only one. I probably have more L5-S1 experience than any other endoscopic surgeon in the world. The endoscopic surgeons I know, they don't do L5-S1 transforaminal. They go translaminar or interlaminar. They don't even bother because it's so hard to do. But we do it all the time. There's a way to do it right, safely. Okay, we're going to head up to L3-4. That's our next disc. I've got my guide wire in, shot. And we're going to take the needle out. We've already made our skin incision earlier. So I'm just going to bring this dilator down over the guide wire. I think there's a little schmutzpa in there. I may have gotten it out. No, no. Let's see. Any more questions from our audience?
No, sir, not at the moment.
So let's run the Deuk laser disc repair animation again for them so they could see what it is I'm about to do here at L3-4.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, so at this point we've entered the L3-4 disc on the right side. I've switched the side of the patient. I've moved myself over to here. I like to operate standing on the side of the patient that I'm actually doing the surgery. It's just better that way. It's easier to do. Easier for me, it's safer for the patient. So I've come over to this right side. Meanwhile, Luis will close up the, oh, let me show you the incision that we did the whole surgery on the left side. See that? It's about a 7mm incision.
Yes, sir.
Okay, so tiny. That's why we call it minimally invasive, because it really is minimally invasive. I hope you're enjoying the surgery, and you know, we're here to answer your questions. So if you have a question, feel free to ask me. I'm happy to answer it. I've got nothing else important to do, right? But operate. But do spine surgery. And the laser, please. All right.
We got a question from YouTube.
Sure.
How deep is the incision?
How deep is the incision? Great question. So the incision goes, like the skin incision is in the skin. It's only a few millimeters deep, but the actual tube that goes from the skin all the way down to the bad disc and into the tear that we're repairing right now, it's a good 6 to 8, or 9 inches deep. It just depends on how big the patient is. So some patients obviously have more soft tissue between the skin surface and the spine. Others have less. This particular patient has about 8 inches from their skin down to their spine. I think that's what you're asking me. All right. There's a piece of herniation right there. Taking its sweet old time coming out. This is the annular tear here. More herniation coming out. So remember, we're starting inside the disc. That's a safer way to do it. But it's not the way everybody that does endoscopic surgery does it in the lumbar spine. That's the way I will always do it because I think it's the safest way to do it. There's another big piece of herniation there. Another herniation, softer. So look at the difference. The blue stuff, this is new herniation. This big yellow thing is old herniation. Look at the difference. The big yellow thing is all scarred up. It's been there for a long time. But the blue one is more recent. And as I've told you guys many times, that herniated discs aren't just one age herniation. It happens over and over and over again. And so you have a population of herniated disc material that's different ages. Some older, some younger. And, you know, the thing is like when you have a herniated disc that causes pain, it doesn't just cause pain once. So what happens is you keep injuring it. Every time you injure it, it flares up. And that's just more herniation that came out. So it's best to get the surgery done that we do, the laser surgery, because once we clean this tear up, it can start to heal. There's another piece of herniation. So we've had some really good questions today from our audience, and I appreciate all the audience participation. Questions are always good. Gives me an opportunity to try to answer them. I always try to answer questions as honestly as I can. I don't have all the answers all the time, but I will give you my best answer. And if I don't know something, I'll tell you I don't know. These surgeries are broadcast free around the world. And they're also stored on YouTube, obviously, because we use YouTube for our live stream. So
We have another question from YouTube.
sure.
Is this a relatively safe surgery? What kind of complications might there be?
Great question. So somebody is asking, is this a relatively safe surgery? The answer is yes. And then what kind of complications can there be? So this is probably the safest spine surgery in the world. And the complications, we've had one complication in 1,400 surgeries. And the complication was an anesthesia complication. It wasn't related to the surgery itself. As a matter of fact, the patient had a problem with their heart. And so they did all the proper preoperative clearance and everything, but still had an issue. So that was one patient in 1,400 surgeries. So I don't think there's a safer surgery out there. Most spine surgery has a complication rate of around, depending on how invasive it is, but anywhere between 5% and 25%. Serious complications. So what are the complications that could happen with this surgery? This is like every other spine surgery in that the complications that we could have are very serious. You could have people dying. You could have people paralyzed. You could have spinal fluid leaks, nerve damage, pneumonia, blood clots, pulmonary embolism, DVT. You could have recurrent disc herniation. You could have bleeding, infections, paralysis, brain injuries, spinal cord injuries, vascular injuries, internal bleeding, spinal instability, hemorrhaging. I mean, there's lots and lots and lots of things that can happen that are bad. We've not had any of those things happen except for one complication in the last 16 years. So the chance of reherniating a disc is around 1%. That's what our studies have shown in this surgery. So 1 in 100 patients will re-herniate. They'll push out another piece of herniation before their disc has had a chance to heal. I get a lot of people asking me, how long does the surgery last? It lasts a lifetime, as long as you allow your disc to heal properly. I don't expect my patients to need more surgery at the disc that we fix. Okay? That said, 1 out of 100 patients do, because they end up re-herniating. Every time that I've seen a patient that re-herniates, they've been doing things they're not supposed to do. Lifting things that are too heavy. Doing like activities too soon, certain activities too soon. So we give our patients restrictions up to 12 months, and I expect people to follow those restrictions. If you do, your disc will heal beautifully and you won't have any more problems. All right, we are almost done with this disc. Then we're going to go for the 5-1 on my side now. See what happens.
We have another question from Facebook, Dominique.
Sure.
How close to the spinal cord are you, and how do you know its location to the laser?
Yeah, great question. So the question was from Dominique on Facebook. How close to the spinal cord am I? Well, the spinal cord is actually pretty far away. The spinal cord doesn't go into the lower back. We're in the lower back. The spinal cord stops at around L1. We're down here at L3-4, so we're way below the spinal cord. Spinal cord's about 6 inches above where we are, maybe even 10 inches above us. So we're nowhere near the spinal cord when we're operating in the lumbar spine. Now, the cervical spine, when we do the neck surgeries on the cervical spine, we're literally just on top of the spinal cord. So we're a millimeter away. So tell me, the other part of the question was about the laser. The laser, you can see, is a little glass tube. And out of the end of this glass tube comes laser energy. But the energy only goes a little way out of the tube. It only comes out 0.5 millimeter. 0.5 millimeter is a very short distance. So as long as I control the tip of the laser, I can make sure I don't do any damage to anything like the spinal cord, because I can see very clearly with this special endoscope. It's a high definition endoscope. I can see all the details of what I need to see so I don't cause any nerve damage or spinal cord damage. I would never blast the laser on the nerve or the spinal cord. I know where they are. I know what they look like. As a neurosurgeon, it's part of my training. We do surgery near the nerves and spinal cord all the time. That's what we do. And I've never had a nerve injury or a spinal cord injury in my surgery, ever. Not even with my fusions. How are we doing on irrigation? Good? It looks like it may be running a little low. That's a bone spur, by the way. Just about done here. 30 seconds, maybe a minute. Great questions today, by the way. I really enjoy the questions.
We have another one from YouTube.
Sure.
What causes the blue coloration on the herniated tissue?
Yeah, great question. So what causes the blue color down there? We inject the blue dye earlier in the surgery. If you rewind and you go back, you'll see. And that blue dye stains one thing and one thing only, and that's degenerated herniated disc. So to have a herniated disc, let's just say you have a herniation today. It happens right now. Then if I put this blue dye in there, it won't stain anything blue. The herniation will be white. It won't pick up the dye. But the fact that it's picking up the dye means that the herniation is at least a few days old. So it's starting to degenerate. And what makes it bind the dye is it's acidic. So acidic means acid. And the herniation normally would not bind the dye. Like normal disc material, normal nucleus pulposus would not bind the dye. So the fact that it's binding the dye tells me it's already being degenerated by the inflammatory process. And it helps me find all the pieces of herniation that need to come out. Plus it helps me see the annular tear the part of the disc that I'm trying to fix to get rid of the pain. We are just here at the end of the disc. This is it right here. So I'm going to clean this up and then we'll be done with this disc. It just turns out that the dye we use is blue, just like Deuk spine. Our colors are blue and gold. So it's kind of cool that our dye matches our colors of our company.
We have another question from YouTube.
Yeah, sure. This is great.
Is
Keep-
an ACDF C5 C6 relatively safe?
All I heard is an ACDF at C5 and 6, and then I couldn't hear anything after that.
Is it a safe procedure? Is it relatively
Is
safe?
it a safe procedure? Well, if I did it, it's safe. But if you do it, it's not safe, unless you're a neurosurgeon. So what I'm getting at, and I'm not trying to be cheeky, is that it depends on who does the surgery. There's a lot of really bad surgeons out there, and they will mess you up. And I wouldn't trust 90% of them. I've seen their work. They screw patients up. It's not intentional, I don't think. I think it's just poor training and poor understanding of how to do surgery. It's mostly poor training. But an ACDF can be very safe, but in 90% of the spine surgeon's hands, it's not safe. So be very careful who does your surgery. Very, very, very careful. There's a lot of people whose lives have been ruined by bad surgery. All right. Now I really am 30 seconds here. That's got to be it right there. Okay. Man. All right, laser out. So let's take a look at the nerve root. This time it's going to be on this side, and it's kind of buried in there. So we're good distance. Let me have a laser. There's a little bit of disc right here. I want to get it out. It's not enough to cause pressure, but you know, I'm here and I don't want to take any chances. If I can easily get rid of it, I'm going to get rid of it. That's it. I love the questions today. Really insightful and engaging. Thank you, audience. We're going to try to do one more disc. Let's see if we can get it.
Stop off, lights down, please.
Scope off. All right, good work. Antiseptic. Let me have the dilator. I'm sorry? I don't know what you're showing me. So what does that mean? Does that mean? I can't hear you. So do you want me to stop? It's real simple. She is. Wouldn't what? I can't hear you. So she needs to. All right. So we're going to stop. We're done. Yeah. The patient had a few PVCs, which is good. We got the disc we wanted to get done. So here you go. All right, she's done fantastic. And you can see there are 2 incisions, one on each side. Any more questions?
No, sir, not at the moment.
All right.
There's a lot of material there, this one, if you want.
Want me to put a stitch? You want me to do it? I can help you hurry up. All right. So if you have any more questions, type them up for us, and we'll do our very best to answer them for you. I think he said, somebody said defibrillator, right? So you know it's a, look, Luis, it's a reverse, Luis.
Yes, sir. Yeah.
It's inverted.
Yeah.
I just want to make sure that's what you're doing.
Yeah.
So she's going to get one stitch and then we're going to put a little Band-Aid on there. And we're going to let her family take her home, recover. She's had a big surgery today and scissor, cut. Good. I got it. Just lay still, you're doing great. Is she okay? How long of a time would you recommend waiting?
When she gets evaluated, like for the when she gets the laser in, when she gets better evaluation.
That's not going to happen till,
Calf
that's not going to happen till, what do you call it? Till they go home, right? I think tomorrow we're going to do a rhizotomy. But how much time till we could do a rhizotomy, do you think? Needle is down.
Thank you very much.
We'll talk about it in recovery, see how she does. We are done. Great job. We're going to put 2 little Band-Aids on. I don't either.
Jordan, can you help me with the camera?
Great job, everyone. She okay? All right, Ray Tech off the field. If you have questions, type them up and I'll come answer them for you. Meanwhile, are you guys broadcasting still?
Yes, sir.
Go ahead and run a comparison again, or a testimonial would be nice. I'm going to call the EBL 3 mil. Dr. Ardik Majan here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had zero pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ari Deuk-Machen. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
Absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you said, what are you going to do now? They said, I'm going to Disneyland. You already went, I could see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk-Machen. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had that.
that's correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Gone.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while?
Yes.
But the symptoms came back.
Came back.
Yeah. All right, well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did orthoscopic.
That's right, arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah, I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues.
Hello, I'm Dr. Deuk, and we're just finishing with our third surgery of the day, and things went very well for her. We actually were able to test the 3 discs in her lower back that we thought were causing her back pain. And sure enough, those 3 discs were the cause of her back pain. So what is it about the disc that causes back pain? Because a lot of doctors don't understand. Well, let's take a look. This is what we call a spine model. It's a plastic spine model that was built so we could show the relationship of the anatomy of the different structures that are important. And you can see we've got 2 bones or vertebrae. Specifically, these are the vertebral bodies. And between the vertebral bodies is something called the disc. And the disc is the source of pain. And it's actually a tear in the back of the disc. I want to show you this tear right here. I think you can all see it right there. Just there. That little red line is the tear. And if we move the nerve root over a little bit, you might be able to see it a little bit better. So let's see here if I can do that. Move the nerve root over. And there's the tear right there. It's that little red, you guys see that right there? The tip at the back of the disc. Now it's red because it's inflamed. And what causes inflammation is the fact that there's a herniation coming out through there. And the herniation itself elicits inflammatory response. You can see behind the disc is the facet joint right there. It's another type of joint. And of course there's nerve roots that come out of the holes. So to fix this patient's back, I came in from the side and went through a hole that's already there called transforaminal. So I kind of had my needle bump against the facet, and then I brought the needle down into the disc right where the tear was. Now, what makes L5-S1 so difficult? L5-S1 is difficult because of these bones here. This is the pelvis or iliac crest bone. These are called pelvic bones. And then, of course, the sacrum. So I put a little toothpick, all right, one of my martini olive toothpicks in there, and it just kind of gives you the idea of just how narrow the path is to get into that disc from the back. It's very tiny and very constricted.